have no disclosures relevant to this topic. So a little bit about the anatomy of the first MTP joint. This is looking at the medial aspect of the joint in the sagittal view. Here we have the medial collateral ligament. The plantar plate is what we're going to focus on primarily here, which is sort of a blended tissue. And I always think of it as including sort of the tendinous portion as well as the ligamentous portion and the plantar plate between the hallux sesamoids and the proximal phalanx. It's responsible for some sagittal plane stability, as well as involved in the plantar flexion aspect of that joint. You can see here, here's the FHB, here's the sesamoid, and here would be the plantar plate tissue, the FHL running between the sesamoids. Looking at an intra-articular view from dorsal to plantar, here would be the medial and lateral sesamoids, the intersesamoidal ligament. This would be the phalangeal sesamoid ligament, which I consider as a blended tissue again with the plantar plate, although they are described often as separate structures. These injuries typically result from a hyperdorsiflexion injury with the great toe. They're often described in the United States amongst American football players. Here's a picture of that position, and this would be how the injury occurs on the field. This first described in 1970s at West Virginia University, and it was associated with artificial turf primarily at that point. Obviously, the turfs have changed a lot over the years. It used to just be a little green pad over concrete, basically. Now turfs are very sophisticated, and there's still a lot of biomechanical testing going on, looking at the way shoes interact with turfs. There's really been a significant decrease in the NFL as the turfs have improved, as have shoe wear. Biomechanics, this was a study done at our biomechanical lab here at the University of Virginia. It found a 50% risk of injury occurs at 78 degrees of anatomic MTP dorsiflexion. And they also found that if you could limit that dorsiflexion to 56 degrees, you could prevent a high percentage of these injuries. And the idea behind that study was to lead to shoe wear advances to try to make shoes that prevented that exceeding 56 degrees. Evaluation of the patient with a turf toe injuries obviously starts with physical exam. Usually they're going to be very stiff, especially in the acute phase due to pain and swelling. They may have early clawing and a severe rupture due to loss of the FHB attachment. You want to look for sagittal plane instability, which is often very difficult due to pain and swelling. And then you want to look for hallux valgus, which I think is, in my experience, more common than hallux varus with these injuries, although you can have either. But you want to look to see if there's also concomitant injury to the collateral ligaments. This is a case. This is a 21-year-old college U.S. football player. He sustained an injury to his great toe in practice. It was 1 week before the season started after a reported hyperdorsiflexion injury. Interestingly, he had had an injury on the other foot in the previous season and had a turf toe plate in his shoe at the time of injury. So you can see that shoe wear is not absolute in protecting against these injuries. His initial presentation, he had significant swelling at the medial forefoot, weak and plantar flexion at the MTP joint, which again is often hard to assess due to pain, and as was the sagittal plane instability, but there was a sense that he had a little bit of instability despite his guarding. Going back to an overview, this is a classification proposed by Dr. Anderson, which I think is commonly used. Grade 1 would be an attenuation of the plantar structures, local swelling, mild ecchymosis. Treatment is essentially symptomatic, often placed in a walking boot for a short period of time, ice elevation, anti-inflammatories, followed by working on range of motion strengthening with a fairly early return to play as symptoms subside. Grade 2 is a partial tear of the plantar structures, and they'll have moderate swelling and decreased motion due to pain. Treatment, boot, toe strapping, preventing dorsiflexion early on to let things settle down and heal, with gradual increase in range of motion strengthening and return to play, usually in several weeks. Often it's helpful to have a shoe modification, such as a turf toe plate or carbon fiber plate, and taping of the toe. Grade 3, these are the complicated ones. This is a complete plantar disruption, maybe through the sesamoids with a fracture. The patient's going to have significant ecchymosis, swelling, going to be weak in flexion at the MTP joint, and oftentimes you will see instability of MTP joint if you can assess it. Treatment, immobilization, or surgical reconstruction. Return to sport usually takes 4 months or longer. Non-surgical treatment consists of toe spica casting, and you really want to limit dorsiflexion for at least 6 weeks. In a high-level athlete, this is often not the preferred method of treatment. Currently, I feel most of us treat many of these surgically. But return to play happens when they can achieve 50 to 60 degrees of dorsiflexion. They have full active plantar flexion strength, and it's usually around 4 months. Surgical treatment, the indications, these severe injuries are fortunately fairly rare, but an unstable joint on exam, retraction of the sesamoids 3 millimeters or greater compared to the contralateral side, a complete rupture of all plantar structures, which can be seen on an MRI, diastasis of a sesamoid fracture, clawing of the great toe, traumatic hallux valgus, and loose bodies within the joint. This is a radiograph of a patient with an injury, and what primarily I look for on x-ray would be any fracture, certainly a dislocation of the hallux MTP joint, and you look for this hallux sesamoid position. AP view looks fairly normal, but if you look at the lateral view, you get a sense that this is fairly retracted compared to the base of the proximal phalanx. A stress sesamoid view can be very helpful. This is a fluoroscopic image taken from a paper by Waldrop et al. In 2013, showing that, and in their paper, they found that an increase of 3 millimeters or greater from the sesamoids to the phalanx equals a severe plantar plate injury. And here's a picture of my patient. The left image is the injured side, the right image is the non-injured side, and you can see a clear difference between the two with diastasis here and retraction on the left. MRI is very helpful in assessing these injuries, especially in the athlete. This is a normal MRI, T2 fat suppressed MRI showing intact plantar plate. This is the medial aspect of the joint, medial sesamoid, and an intact plantar plate here. This is my case. This is the medial joint. You can see complete disruption of those structures on T1, as well as fluid within the plantar plate on T2, and obvious sesamoid retraction. This is the medial aspect of the joint, and this is the lateral aspect of the joint, again demonstrating a complete plantar injury. Also on this patient, looking at the T2 coronal view, you can see as disruption of the medial collateral ligament as well. This is an intraoperative photo showing that medial collateral injury, as well as the defect in the plantar plate. My surgical technique usually involves using either number 2 or 2O or 0 non-absorbable sutures for the medial and lateral plantar structures, although I think there may be a trend moving towards focusing primarily more on the medial structures than fixing the lateral plantar plate aspect. You may use anchors or drill holes to secure the plantar plate. If it's complete avulsion off of either the base of the phalanx or the sesamoids, you may pass drill holes to put your sutures to reattach that. I do favor, if I'm going to repair medial and laterally, a 2 incision technique, although other J-shaped or L-shaped incisions have been described. I use a medial based incision primarily, as you can see in that original picture, and then a plantar lateral incision to get to the plantar aspect. I always make sure to look at the medial collateral ligament, because again, in these athletes, I find that is also frequently injured. This is a photograph demonstrating the post-repair of that same patient. These are non-absorbable Ethibond sutures reinforced with an absorbable vicryl suture. The key thing here is this is the image on the left is the fluoroscopy view before the repair, and on the right is after the repair. And you can see that we've reestablished that relationship between the sesamoids and the base of the proximal phalanx. They're moving as a unit as the toe goes into dorsiflexion. Post-operatively, I tend to keep these patients non-weight bearing for about 2 to 4 weeks. I'll put them in a bulky dressing with the toe strapped in a slight dorsiflexion, or excuse me, slight plantar flex position. I do like to get them moving as quickly as possible, focus on passive plantar flexion, some active dorsiflexion, but you want to avoid excessive dorsiflexion, obviously, to protect your repair. Weight bearing in a boot with the hallux taped in a bit of plantar flexion. The goal is to gradually decrease that plantar flexion, obtaining neutral dorsiflexion at about 6 weeks, and then increase by 10 degrees per week after that. Transition to a stiff shoe at 8 weeks with a turf toe carbon fiber plate. I think a reasonable goal is to return to some light running and training at about 3 months. Again, we're trying to get people back to sports between 4 months on the early side, but often it takes up to 6 months. And again, the shoe with the plate is helpful. Outcomes: most mild injuries will return to full activity. The more severe injuries can often return. The patients with the more severe injuries can often return to their sport, but they don't necessarily quite achieve 100% long term. If you look at them critically, Dr. Anderson's study, he had 19 injuries, 9 of whom underwent operative repair, and 17 of these patients returned to sport. Clanton et al. Found that 50% had symptoms still at 5 years. And they all found similar results, reporting stiffness in a lot of these patients. So in summary, patients with turf toe injuries, they're severe injuries. If they're missed, they're devastating. They're much easier to repair early, although there have been some reports on delayed repairs. I find that the tissue tends to form a lot of scar tissue. It's hard to tell what's normal tissue after about 3 to 4 weeks. So if you can identify them early, I think that's key. And identifying which patients truly need surgery based on instability and retraction of those sesamoids and loss of that motor unit is very important. But if you repair them well and rehab them appropriately, which is crucial in this situation, most can do well and return to their sport. Again, thank you very much for inviting me to present it at your meeting. Hope you enjoyed it. Thanks.